I would like to start with thanking the organizers for giving the opportunity to be able to talk about the research that we've been doing. And it's been a collaborative study between a couple of hospitals in Italy and the Netherlands. And it's about how to use platelet RNA for novel diagnostic tools in pancreatic cancer. As a disclosure, I have to state that Professor Woerdingen has shares in Grill, a company from Illumina, and he receives research funds. We've been talking about pancreatic cancer, and I think we all know that pancreatic cancer still is a lethal disease. And even though we've been improving on therapies, specifically on chemotherapeutics, and we're going into an era for neoadjuvant treatment, I think one of the questions that we still need to ask is how to diagnose this tumor and how to be certain about this diagnosis before we can move forward towards treatment. And what we currently rely on is a tumor marker, CA19.9, which is an antigen that we can detect in blood, but it has some draws to it. And one of the things is that it could give, for example, a false positive if there's a high bilirubin level. And the sensitivity and specificity are okay, but they are not as good as what you would want if you're going to treat a patient with neoadjuvant chemotherapy, for example. And especially if you have early stage disease, the marker can be a little low. So what we need is a new diagnostic method, diagnostic tool. And what we're looking at in our research is tumor-educated platelets. And our group has been doing research about these platelets for a while, and maybe you've already heard about it, but platelets, of course, we know all for the coagulation that we use in the human physiology. But what we now also know is that these platelets circulate in the bloodstream, and next to the fact that they have a function, they actually also can take up particles from the body, so also from the tumor. So if they pass a tumor, they can actually take up RNA, they can take up proteins, DNA pieces, and this is what you can use for diagnostic, and that's what we call a tumor-educated platelet. So how does that work? And what we've done before is that if you take those platelets from the blood and look into them, you can actually see that they show a different repertoire of RNA. And this RNA profile you can actually use for identifying different diseases. And what we've shown in 2015 is that if we look into the RNA from these platelets that you can just take from the blood, you can actually use that for cancer diagnostics. And what they did here is we looked into several different tumors to see if we can distinguish healthy from cancer. And that seemed to be working quite well. But what we're looking for right now is to specifically identify profiles that are belonging to pancreatic cancer. So we aim to evaluate platelet RNA for diagnosis of pancreatic cancer. And I'll show you what we've done so far. So what we actually need is 1 tube of 6 ml blood, standard workflow. And we've been getting blood from 2 hospitals in the Netherlands, the Pisa University Hospital and Massachusetts. And what we then do is we use an isolation method for the platelets. So you have your 1 tube of blood, you centrifuge it a couple of times, you have a pellet of platelets, and this platelet batch you use for RNA isolation. And this RNA is then next subsequently used for sequencing. And then what happens is we sequence a lot of patients and a lot of blood and a lot of platelets. We identify what kind of RNA is in there, and then we use an algorithm to train and to identify what is the optimal panel, what kind of RNA is really distinguishing cancer from pancreatic cancer from healthy patients, and can we then train it to really be used as a diagnostic tool. So in the end, we want to have a performance that outperforms the standard CA19.9. So this is the patient cohort that we'll be using for the first evaluation. So you start actually with a training cohort where you try to identify the most optimal algorithm with the most differential RNAs, and then you implement it in validation studies. So we have a total of almost 300 healthy controls, 122 cancer patients in different disease stages, early stage and late stages, and we have a couple of benign diseases to really show that our test works in a normal outpatient clinic that you would see in an HPB outpatient clinic. So we have benign diseases with people that have gallstones, chronic pancreatitis, low-grade IPMM, to really mix up the batch of healthy that we have. And next, what you do see in a lot of diagnostic research is that they use a healthy batch, which are normally the people in the lab working, giving some blood, so young people. But we really try to find an age match group. So we've been having a lot of efforts to finding a good control group to really try to get the age level comparable between the cancer patients and our healthy controls. So first thing we ask, of course, is there a difference between RNA from healthy controls and benign disease between pancreatic cancer? And what you see here on the right side is a figure where we show all the genes that are identified in the RNA from the platelets, and we were hoping that the cancer will be different on the other side. So what you see here in the red box, there is an enrichment for the healthy patients that show a different signal compared to cancer patients, which are actually enriched on the left side of the figure. So this is actually promising, so then we can move forward with the algorithm training. So what you see here is actually, if we have 2 validation cohorts that we've been using, is that over 90% of our cases are actually identified correctly by the algorithm, saying it's cancer or it's healthy. And then, of course, this is how it really looks. Like, this is one of the validation cohorts where we have 28 patients with cancer, and 26 of them are actually identified correctly. And you have to keep in mind that, of course, this is also early stage, so we have a couple of first and second stage disease in here as well. And this yields a total specific sensitivity of 93% and a specificity of almost 90%. And if you think about how CA19.9 performs, the numbers you saw before were actually numbers from literature, from meta-analysis, and these are the numbers that we have in our outpatient clinic right now, is that if we just test for CA19.9, we have a sensitivity of almost 80% and also a specificity of 85%. And if we would use our tests in our cohort, we actually really boost the sensitivity of our tests. And one of the other things that we know from CA19.9 is that bilirubin can be a confounder. And in our tests, at least, we know that there's no correlation between the level of detection and the level of bilirubin, which is a promising sign. So what are the future perspectives of this study? We aim to work towards a clinical implementation, and for that, of course, we want to include other hepatobiliary tumors to really see if it's a really different signal from, for example, an HCC compared to pancreatic cancer. And we will need a further large-scale international validation that is currently ongoing. But there's another thing that I think is important. If you have a test, I think there are a lot of ways to implement it, and I think one of the things that we're also working on right now is seeing if this test can be implemented also for monitoring disease. Can we really see if the tumor is going down before or after surgery? Can we use it in neoadjuvant treatment to see if the patients actually respond? Can we see there's a difference in signal? And of course, can we detect premalignant lesions, and not just the low-grade ones, but then the high-grade ones that you want to do surgery on? So that is work ongoing. So to conclude, we've shown that RNA from platelets actually have a very different profile in pancreatic cancer compared to healthy patients and benign disease. It shows to have a good sensitivity and specificity, especially if you compare it to the standard CA19.9. Bilirubin is not a confounding factor in this test, and I think the tumor-educated platelets are really a new biosource that we can use for future diagnostics. And I would like to thank you for your attention, and I'd be happy to take any questions.
Thank you for an excellent presentation. I'd just like to ask you, although bilirubin is not a confounding factor, what percentage of your patients presented with cholangitis, and did this have a role to play at all?
So the sampling that we have is at the moment that they're at the outpatient clinic when they don't have cholangitis. So that's a subgroup that we have in the benign disease, and those we classify correctly, but we don't have a group yet that are having pancreatic cancer and cholangitis at the same time. So that's something definitely that we'll need to find to further implement the test.
Thank you for sticking to time. Are there any other questions? If not, once again, thank you for an excellent presentation.
There is a question there.
There we are. Oh.
Thank you for your excellent presentation and to the point, especially with surgeons. I'm asking why platelets by itself did you select for searching RNA? I did not get that point. Why platelets, not RBC, not white blood cell?
Yeah, actually, we did some research to that before, and we know that platelets, they have a function and they seem to take up things. So an erythrocyte circles around, but it doesn't seem to pick up signals, and platelets do. And that's actually how we found out that they changed their repertoire of RNA.
And about the cost of this, it will be high?
So far, yeah, it's depending on the sequencing, of course. And that will be the limiting factor, but the cost of sequencing has been going down quite a bit from 1,000 a test to now below 150, so it's getting there.
Thank you very much. Thank you.
Okay, in the interest of time, I think we need to move on. Thank you very much for your presentation.